All right, so thank you very much for taking time to be part of this parallel session. We're going to start right away. You've been told about the QR code, so you take it, scan it on your phone. Whenever a presenter comes on, you just scroll and find their name so that you are able to score them by the time they finish. So we can go ahead. Maria, you can start. Karibu.
Good afternoon. So I'm glad that we are in this session and a few of us are here. I was hoping for a wider audience. You see, I even dressed up for it. So I'm Maria Angelica Remamu, and I'm a second-year PhD student, and I'll be presenting my thesis protocol for effective coverage on antenatal care, a situation analysis and evaluation of specific packages of intervention. So this is my supervisory team. I have Dr. Uzo Egere, Dr. Leonard Katarambura from the University of Dodoma, Dr. Alice Ladu from Liverpool School of Tropical Medicine, and Professor Charles Ame. So they're helping me put the bits and parts together. So Tanzania, according to the 2015-2016 Demographic Health Survey, has a maternal mortality ratio of 556 per 100,000 live births. And this is far higher than the Sustainable Development Goals ratio, which we're supposed to meet by 2030 of 140 deaths per 100,000 live births. So according to the previous presentation, we have made significant improvement, but it is yet to be revealed. So more than 50% of the maternal deaths are preventable, and most of them are due to the 5 main causes, that is postpartum hemorrhage, preeclampsia, and antepartum hemorrhage. So more than 90% of the maternal deaths also occur at health facilities, and that means these women are dying in our own hands, and we could do something to change this. So Tanzania has been struggling to meet the global maternal goals. Despite the current improvements that have been made, we still have some strides to make in maternal goals. And the quality of services in Tanzania is suboptimal, and that's why we are still having the high maternal mortality rate, and also most of the deaths are occurring in our health facilities. So improving the quality of care for maternal care will definitely improve the maternal morbidities and maternal mortalities, and that means adhering to the guidelines and also adhering to the standards of care and improving the respectful maternity care during care to women. And at the same time, antenatal care and postnatal care is a good platform for integration of TB, HIV, and malaria preventive services, which are among the leading causes of maternal morbidities and mortalities. So, as I already mentioned in the morning, effective coverage is a standardized way to measure quality of antenatal care, and this can be measured through quality-adjusted care, and it adds a component of quality to the care that is given to women, and this is the proportion of the population that receives quality care and gets positive outcomes. So the Global Fund project, which is being implemented in Tanzania, Nigeria, and Kenya, aims at improving the quality of antenatal care services and postnatal care services, increasing the integration of HIV, TB, and malaria in antenatal care and postnatal care services, and also doing capacity building of the health facilities through training of the healthcare personnel, and also at the same time supplying the health facilities with equipment. So just in a nutshell, when we talk about specific packages of intervention, when we look at Tanzania, only 43%, this is according to the Service Provision Assessment of 2015, only 43% of the healthcare personnel that are providing antenatal care have been trained in the last 2 years. And also, as Dr. Mzee had already presented, we completely almost lack integration of TB services in antenatal care. And we actually even don't know the extent to which pregnant women are affected by TB, and also the extent of implementation of the new guideline and the quality of care that is being provided during antenatal care is also unknown. So another package that is also still, we might show the code coverages of testing for malaria. Women testing for malaria is very high, but when it comes to the service provision and assessment readiness of Tanzania, it is still low. For instance, if you look at this is the chart that is from the Service Provision Assessment Survey in Tanzania, and you see these are malaria-related interventions during antenatal care, and as you can see, we are still performing very poorly in some of them, actually in all of them, since most of them are below 50. So despite that, it's a wonder how we can still say that we have very high coverages of maternal indicators when it comes to prevention of malaria. So the main objective for my study is to determine the extent of adaptation of the WHO 2016 antenatal care recommendations, and also effective coverage of antenatal care quality improvement package in Tanzania, Kenya, and Nigeria. So my first objective is a systematic review, which I presented in the morning, and it is quality adjusted coverage of antenatal care in sub-Saharan Africa. And the second objective is to determine the extent to which the current antenatal care guidelines in Tanzania, Kenya, and Nigeria have been adapted to the context of the country, and also to evaluate the impact of the implementation of the Global Fund Project program on quality of care in antenatal care and postnatal care in Tanzania. So for the first objective, which is to determine the extent of adaptation, I'm going to develop which is to do the systematic review. We already developed a such strategy, and the systematic review is already registered on Prospero, and we search databases using the LSTM's EBSCO discovery tool. And as I presented today morning, we had 6,301 studies, and the results have been stored in EndNote, and we're using Confidence as a platform for the systematic review. And at the same time, the data will be extracted using Confidence, and it will be exported to Excel and analyzed through SPSS. For my second objective, which is to determine the extent of adaptation of the WHO 2016 recommendations, we are going to do a mapping of the antenatal care guidelines, that is for Tanzania, Nigeria, and Kenya, to determine to what extent they have adapted the WHO 2016 guidelines in their guideline, and the context, what have they eliminated and what they have included to see the standard of care in the guidelines that they are using. And then, because these guidelines are being adapted to the context of the country, we would like to find out what are the factors that actually influence the adaptation of these guidelines. And therefore, we're going to do key informant interviews with the policymakers and Ministry of Health personnel who are responsible for development and adaptation of these guidelines. And because sometimes we may have guidelines, but at the same time they're not being fully implemented. So we would like to know the extent to which these guidelines are implemented. And for that reason, we are going to do an observational study in some of the health facilities in Tanzania on the antenatal care practices to see if they're fully implemented or they're fully practiced. So for the third objective, which is to assess the impact of the Global Fund program in improvement of the quality of care in Tanzania, we are going to do an interventional trial study, of which we already have 20 healthcare facilities that are under the program of the Group of Fund project, and these are going to be the intervention areas, and then we are going to select 20 healthcare facilities by proportion probability sampling, which is we're going to select them according to the levels and the levels of the health facilities in order that they match the 20 healthcare facilities. And these are going to be the control areas. So we are going to use the WHO service availability and assessment tool, and also the standard-based audits to look at the quality, the standards of care that is being provided, and also the availability and readiness of those of the antenatal care services in these two areas. And at the same time, we're going to do key informant interviews in order to assess quality of the healthcare services that are being provided at the two areas. And also, we're going to compare the baseline and quarterly and endline monitoring and evaluation data for the intervention area to see the progress of the care that is being given in the intervention areas. So my current progress so far, as I already mentioned, I've already started my systematic review, and I already finished my first year for the PhD, and I'm in my second year, and my study protocol is still under development, and the data collection is supposed to start in the middle of this academic year. Thank you so much.
Thank you so much. I'm hoping that you've been able to actually get to the QR code. You've scanned it. You've been able to fill. I know there's a part for the QA for the question and answer. I think that we'll be able to do it later at the very end, but make sure that you're able to capture those other aspects. So I would like us to welcome the next presenter, but I hope you have taken note of the areas that you'd like to highlight so that you can strengthen her work. Just take note of that. So can we welcome Zainab? Welcome.
Okay, thank you. You're welcome again to proceed with the presentation. Zainab Hassan Suleiman, second year PhD student.
Yes, so for the part of on the two where we are trying to rate them, the part for question and answer, you can just move to the next because it's not you are not restricted. Move to the next so that now we're able to actually have her do the presentation. But when she will go back to the question and answer, you'll be able to fill the part of the respective presenters. Okay, thank you. Sorry for that.
Thank you. As I said before, I'm Zainab Hassan Suleiman, second year PhD student. Now I will take you through with my PhD work that is improving the effectiveness of reproductive health in service capacity strengthening program. It will be a comparison of blended learning and face-to-face to see the effectiveness of these two training approach. Sorry. Here is my presentation outline. I will talk a little bit about background, research objective, methods and data collection, timeline for data collection, and I think also I will talk about my progress and next step. I forgot to put there. As I said before in the morning, just as a repetition on burden of maternal death. Still, we are struggling on this issue. Despite many action and intervention, similarly with pregnant mother or mother who are going for delivery, they are delivered by skilled health personnel, but still we have this problem. And in Sub-Sahara alone, as I said before, is account about 70% for this burden of maternal and newborn death. Here is a trend about maternal death. Because my PhD work, I will intend to research in 3 countries: Kenya, Tanzania. It's not the 3 countries, it's the 2 countries, but it's the 3 parties: Kenya, Tanzania mainland, and Zanzibar. So here is a trend on maternal death based on the study areas. So MMR in Tanzania, according to TDHS 2015 and 16, it was about 556, but the UN estimated on 2020 it was about 238. And for Zanzibar, as Dr. Camilla presented yesterday, we are in 162 according to DHI. Ministry of Health and DHI data. For Kenya, is a correction a little bit. There is MMR of 362 according to KDHS 2014, and UN estimated by the year of 2020 is about 530. So here is status of maternal death in study areas. So as I said before, I'm intending to do a comparison of the effectiveness of the 2 training approach. So building the capacity of healthcare workers through in-service or in-house training is promote the acquisition of knowledge, skills, and competence to provide integrated antenatal and postnatal care services. And regular training is essential to guarantee that healthcare personnel maintain their accreditation. As I said, lesson learned from COVID, during COVID pandemic, the face-to-face, it was very challenging. So we need to have an alternative to that method. We need to move from traditional face-to-face, and then we need to move on blended learning. Blended learning, as I said before in the morning, is a combination of online learning and face-to-face. So blended learning is sure there is more effective when you are doing in-service capacity building, because it reduces the shortage of staff during the training. So the service in the facility, they going very well and they proceed, and the absenteeism for the healthcare workers is reduced, and the challenges of availability of service during the training is also minimal. In my PhD work, the broad objective is to compare the effectiveness of blended learning approaches to face-to-face, enhancing the capacity of healthcare practitioners in lower and middle income countries in the field of reproductive, maternal, and newborn health. And here I have specific objective. The first one is conducting a systematic review, as I spoke it before in the morning. So on the systematic review, currently I'm on data extraction, so I have already finished about all searching, screening, title and abstract screening, full text screening. Now I'm on data extraction. So I didn't talk more about this systematic review because I have already talked in the morning. So the second objective is to compare the effectiveness of 2 approaches as I said before, blended learning and face-to-face, to see the effectiveness of this training modality. And the third one is to determine the cost effective of the blended learning compared to the face-to-face. So on these two objectives, I will use mixed methods. So there is, I will collect data from quantitative and qualitative. So I will use focus group discussion to collect the data, qualitative data. Objective structured clinical examination also will be used to see to examine the skill of the participant during the training. And self-administered questionnaire also will be utilized to get the participant to know the changing in knowledge, skills, and so on. So I'll take you through a little bit on the description. It is continuous. The essential antenatal care intervention and essential postnatal care intervention are intended to be implemented as continuum of integrated care. These two groups will receive similar training package with similar characteristics with the participant chosen from selected health facility. Those who are responsible provide care or service in the ANC and the PNC area. Here I will give a brief explanation in order to understand what I mean. Because this PhD work, I will intend to have an intervention. I will have two cohorts. One is a blended learning, so I will have participants that will undergo blended learning, will undergo ANC, PNC training by using blended learning alone. And that's the second arm, I will have the participant that will undergo entirely face-to-face. So that's why I said, and these two groups, they receive similar content and they receive similar content and they have similar characteristics. As I said before, my participants, it will be healthcare workers. It includes nurses, midwifery, obstetrician, different cadres, but must be a healthcare workers from the selected facility. So I will work with Global Fund facility under this project, LSTM project, from Kenya, from Dodoma, and Zanzibar. From Kenya is about 64 health facility. Dodoma is 20. And Zanzibar is about 10 healthcare facility. This healthcare facility include primary, secondary, and tertiary facility. So I will have participants from those 3 stages of healthcare facilities. As I said, study setting, I don't have I can't repeat this one because I have already said. Study population, as I said. So inclusion, as I said before. Sample size and sample techniques. So this area, still I'm working with the statistician and discussing with the supervisor, but I do, I have a draft. I use multi-stage sampling, and I got a total number of 244, but I will discuss more with the statistician and my supervisor to see this sample size. It could be enough, or it depends on also allocation of the money and the time for the study. So I will discuss more about this, and I will come with the conclusive later on. Data analysis. I plan to analyze quantitative data, and quantitative data will be coded and analyzed using SPSS version. Qualitative, verbatim, and tone from responses will be transcribed and organized into meaning units to create a code and subcategories. The units will be assessed and reassessed to reflect similar statement and to obtain category for analysis. On the side of cost analysis, we will consider both blended learning training package and the face-to-face training package, and cost will be converted to the USD from local currency. So When we use Kenya shilling, then we will convert to the USD. And when we use Tanzania shilling, after that we'll convert to the USD. On this issue of cost analysis, so we will obtain all information about the cost, direct cost and indirect cost from the blended training and from the face-to-face training. And then after that, we will compare and we will see which one is more costly and which one is less cost. Data analysis framework, as I said before, I will plan to use Philip return on investment ROI framework. So I will utilize all 5 levels of the Philip ROIs. So I will look participant reaction as a level 1. I will look knowledge and skill as a level 2, application and implementation, level 3, and I will look also results in terms of health outcome. This in level 4, I will take a time after training because we plan to have this intervention. So we are training the participants. Before training, we are collecting a data. And after training immediately, also we are collecting data. And also I have a plan to collect the data after 3 or 6 months. It depends. After conversation with my supervisor, we'll agree if we can take 3 or 6 months after training in order to obtain the data from healthcare workers while they are working in their facilities to see the impact of the training and in improving the quality of service and reducing the maternal and the newborn death. And level 5 on return of investment, this is dealing with doing a cost evaluation of blended and face-to-face. Ethical clearance and consent for participation. Ethics proof has already been obtained from LSTM since 2023. Full study protocol will be completed. Still I'm working on the full study protocol. And ethical proof will be sought from the study area before commencing this study. And detail of the study will be given to the participant in the form and information sheet that they read in the advance and will keep for the reference. This is my timeline for data collection, but still I work on, so I will refine it. But for now, just I have this short plan. As you see that protocol development is, hopefully it's complete in this, I'm not sure, but maybe in the early in the first of on Q4. And other things will be going according to my timeline. Thank you so much. I would like to thank my supervisor team from LSTM, Professor Charles, Dr. Uzo and Dr. Elizabeth, and from Bukono University, Professor Alexander Tubika, and from SUZA, State University of Zanzibar, Dr. Salma Mahmoud. Thank you so much. You're welcome.
Thank you so much for the good presentation. So I hope you're taking note, you're able to rate. So can we welcome Uni to do her presentation?
Next.
Okay. Hello, everyone, and good afternoon once again. I am Umi Rahmat, and
we would request that you're audible enough so that I can hear you.
Okay, good afternoon, everyone, and thanks for having me again. And this time around, I'm going to walk you through my study protocol, which is still ongoing. So hopefully, I would be expecting more of comments than questions. So my topic is, and it is related, it's going hand in hand with my systematic review, so you will come across lots of similar things. So my topic is prevalence of domestic violence in Global Fund supported health facilities, focusing on screening challenges and women's perspectives in Kenya and Tanzania. So these are the, oh no, what did I do? These are the outlines I would like to cover today: my background, my objectives, the methodology I intend in using, and the progress I've made so far, and the next step I am willing to take. So as discussed earlier today, domestic violence has serious consequences for both maternal well-being and child health. This could result to injuries to the uterus and all sorts of pregnancy-related complications. The WHO reported that 1 in 5 women experienced DV during pregnancy or within the first year of giving birth. So domestic violence is a common thing in most societies, including high-income settings. Just that those living in low and lower middle income countries has 50% higher chance of experiencing domestic violence. And also there is limited literature on the prevalence and interventions to identify and manage domestic violence during ANC and PNC care within these settings. So as a result of all of this, 20% of perinatal mental health conditions lead to suicidal thoughts, or could lead to suicidal thoughts or self-harm tendencies, and so on. So as said earlier too, knowing the effect of domestic violence among this population, it is very important in providing appropriate support and interventions. And then the WHO came in, they they launched new series of recommendations to improve the quality of antenatal care, in which they also included the assessment and management of domestic violence during these visits. And also, under the Global Fund ANC-PNC Quality Improvement Program supported by Takida, LSTM is building the capacity of healthcare workers to identify and manage domestic violence in selected health facilities. So now I will walk you through my study objectives. The first one is a systematic review, which I've discussed already earlier today. And then the second one is a bit similar with the systematic review, is to assess the prevalence of domestic abuse among pregnant and postpartum women in GF-supported health facilities in Kenya and Tanzania, and then to explore the barriers and facilitators to routine screening of this domestic abuse during the ANC-PNC in Global Fund-supported health facilities. And then the last is we would like to understand the perception of women to implementation of, to receiving these implementations of domestic violence screening during the visits of ANC-PNC in GF-supported health facilities. So for my methodology, I'm intending in using mixed methods, and for the study setting, it's going to be a multi-site study, which will be conducted in 3 districts of Tanzania and 3 counties of Kenya. So all of these I'm saying have not been finally agreed. So this is sort of like a draft. So a total of 30 GF-supported facilities will be randomly selected from the counties or districts of Kenya and Tanzania. So for the participants, I'm intending in including pregnant and up to 6 weeks postpartum women, aged 18 and above, and then and who are actively seeking ANC and PNC within the chosen facilities. So before starting the data collection, we would recruit adequate research assistants that will help us in collecting the data, and then we will conduct training for them on procedures for data collection, safeguarding, and confidentiality. So I'm emphasizing on the safeguarding part because I'm dealing with a very sensitive issue, domestic violence. So we're going to really focus on this part. The study protocol will follow the WHO recommendations on safety when researching violence against women. So this WHO recommendation advises researchers to conduct violence-related interviews in complete privacy, with the exception of children under the age of 2. And then it has a whole checklist that will help you as a guide. And then women will receive a complimentary brochure on mental health services in case they do encounter any difficulties while exposing their experiences. And also women who discloses experiences of domestic violence will be given additional support. Ethical guidelines will also be strictly adhered to throughout the study. So going back to the objectives, I would just like to give a little more details on how I intend on collecting the data based on the objectives. So for my first objective, to assess the prevalence of domestic violence among these sets of population, I'm intending in using the WHO multi-country study questionnaire. Why I'm using this is, so far, while conducting my systematic review, I've came across so many studies that have used this tool, but I'm yet to confirm on completion of my systematic review. So this WHO multi-country study, it comprises of different sections like respondent and her community, general health, her reproductive health, about current or most recent partner violence, attitudes toward gender roles, any injuries and impact, and coping. So for the second objective, for the barriers, to assess the barriers and facilitators from the healthcare workers that were given the training, we intend in using focus group discussions with the healthcare workers so that we do explore these barriers and facilitators which they might be facing. And then the last is for the women. We're going to conduct an in-depth interviews with them during ANC and PNC to understand their perception of the routine screening of domestic violence they might be receiving. So for my data analysis, I'm intending to use the InVivo software for the qualitative part, and then for the quantitative, I'm willing to use the SPSS. And then finally, this is my timeline. I'm currently in my systematic review, hoping to working all together for my systematic review, my study protocol, and trying to complete my ethical applications for the various countries I intend in collecting my data. Thank you very much, everyone.
Thank you so much. And again, I want to request that we rate. And please take note. I know you gave her some comments also in the morning, but we really want to strengthen their study, so please take note of that. So I'd like to welcome our very last presenter. Then please prepare your question and answers so that we can be able to support them. You're welcome.
Thank you. Okay. Good afternoon, everyone. So before he finishes setting up, I do apologize. I have a very bad cold. I picked it up on my way here, but it just became very serious this afternoon. So I've been taking paracetamol and all that, so I have congested it. So Peter, in case No, it's okay. I can stand. But in case I can't answer the question, it's the cold. Yes. Yes. So mine is a little bit different from what they're presenting. I'm going to present the preliminary findings of the preliminary results I have. So this is actually just a little bit of my findings from one of my the objectives that I have. So I intend to follow this outline. So my topic, as I've mentioned before, is on improving the effectiveness of skilled health personnel in reproductive health services in Nigeria. The first objective is my systematic review, which I have presented this morning. So this is what I'm going to be talking about today. What is the effect of work-related stress on skilled health personnel's effectiveness in reproductive health services in northern Nigeria, and what support systems are available? There are other aspects of the research, but I'm not going to look at that today. So we all know about the global crisis of human resource for health. This is from WHO. Actually, recently, they estimated by 2030, there will be a shortfall of about 10 million human resource for health. And most of this is in low middle income countries, especially sub-Saharan Africa. And this came about from chronic underinvestments over time in education and training of these skilled health personnel. And then sometimes mismatch between education and employment status. When I was doing the data collection in Nigeria, I found it really strange. I went to a facility, they had 30 volunteers. These are people that are called volunteers. These are community midwives that I talked about. They finished school, they are volunteers. Meanwhile, there are only 2 people that are actually employed in the facility. So it's not that we don't have the health workers, but even the employment, there's a mismatch. And then, with the COVID-19 pandemic, this wasn't the global workforce crisis with all the brain drain that we're seeing in our countries. And I've talked about this crisis being worse in low middle income countries. So there is a forum on human resource for health. WHO realized that this is something that is really important, and they came out with three key areas of action. And what they say is that healthcare workers deserve more than just a thank you for the work they are doing, which mostly as healthcare workers, we know you don't even get the thank you from the patients or from the management or whoever. So that they actually deserve to have quality education, they deserve to have safe working conditions, they deserve decent pay, and they deserve respect, and they deserve every effort, WHO and every other person that is responsible for them, to protect them. So it is really important to protect the existing health workforce, to invest and prioritize in actions, that will retain them, and then to partner with other people so that they can be supported. So this is a definition of work-related stress from WHO. Work-related stress is the response people may have when presented with work demands and pressures that are not matched to their knowledge and abilities and which challenge their ability to cope. And they classified this generally into 2 parts. So this stress can be from work content, which is, the workload, the participation of the health worker in decision making, monotony, very boring work. Sometimes people do the same work every day and it becomes really boring. Then the context of the work. So this is where the pay comes, job insecurity, unsupportive supervision, sometimes bullying. Sometimes people have unclear roles and lack of structure in organizations. People don't really know what they're going to do every morning when they come and all that. So WHO also recommends that there should be at least 4.45 doctors, nurses, and midwives per 1,000 population. So I really don't want to dwell too much into the background of Nigeria, because I know while I'm presenting this, I would have presented a lot on Nigeria. So that is why I'm just introducing Nigeria here. In Nigeria, this ratio is 2.1 per 1,000 population. That was some time ago. I'm sure it is lower than that. And there are several studies that have been done on work-related stress in Nigeria, and they have found that the prevalence of work-related stress is 60 to 85%. So the research question is, what is the prevalence of work-related stress? What are the causes of this work-related stress? How does this work stress affect health workers, and how do they cope with this work-related stress? And I wanted to find out if there was any support system available to them. So the study, the methodology is really very long, but I have shortened it. It's a mixed method study. I had a qualitative and a quantitative bit. The study is done in 3 northern states. So Bauchi is in the northeastern part of Nigeria, Kaduna is in northwestern part, and Kwara State, north central part. Maybe somebody will ask, why northern Nigeria? I already have that in the background of the study. Studies have shown maternal mortality and all other health indices are either double or more. The worst statistics are in northern Nigeria. So that's why we selected that. And that is the population of studies skilled health personnel. That is a definition I've already given this morning. So in each state, we selected 3 local government areas. And this was done because apart from being a big state, each state in Nigeria is divided into 3 senatorial districts. So there are 3 senators that are elected from each state. And most of the time, these senatorial districts are sort of different from each other. So we selected 1 local government area from each. And we selected in total 48 facilities. So in each local government, we select 2 primary healthcare, 2 private healthcare, 1 general hospital, and in each state we selected 1 tertiary health centers. So for the quantitative bit, we did a cross-sectional study. We have a questionnaire. There's the work stress questionnaire by Holmgren. This was developed, I think, in 2006, and it has been tested in several settings. That was the questionnaire that I adapted and added a few questions to it just to fit in our own context. So that's the questionnaire that we used. And this questionnaire was loaded onto Survey CTO. So the qualitative aspect, I did a focus group discussion with a group of nurses and midwives, a group of doctors, and a group of community health workers. Like I said, in Nigeria, these are the people that we term as our skilled health personnel. And I also had key informant interviews with maternity unit heads. So I had a total of 9 focus group discussions and about 7 or 12 key informant interviews. 7 key informant interviews, yes. So this is just a summary of the result. This is just that little bit about work-related stress, but note that for my data collection, I've taken quite a lot of data. So I'm just presenting this bit about work-related stress. Later on, when I come to write it up, I have to relate this data to other data I've collected, like I've done health facility assessment, I've done health worker observation. So I have to relate it. You know, when I start calculating regression, how does availability of equipment affect, you know, how stressed the workers are. So this is just the findings as they are. So based on our calculation, sample size calculation, we got a sample size of 193. So, but in the questionnaire, 194 people completed it. Most of them are females. You can see from the table, I hope it is clear, this is the range of health workers that answered the question. Most of them, the mean age was 32 years, and about 43% of the people that completed the questionnaire worked in labor ward. Some of them worked in antenatal care or family planning. And in terms of workload, about 79% of them worked between 48 to 60 hours in a week, and about 37% worked for more than 60 hours. 25% of the people that we saw see more than 40 patients in a day. So from the study, part of the questions, you know, you asked, are you stressed, you know, regarding your work? There's a question like that. So those that answered yes, 76% of them answered yes, that they are stressed in their work. And then also, some of these responses is what is in the questionnaire. You can see the causes now of what is making them stress. You can see workload is taking the highest, which is like 41 or 40, almost 42%. And then lack of manpower. But when you say lack of manpower, I think you can jumble that up with the workload, because if you have enough staff, your workload will be less. And then there are some other things. So for the qualitative bit, we transcribed it and we used in vivo to just come up with a quick themes. So these are just initial themes that we're getting from the questionnaire. So some of the themes that are coming out with regard to the cause of work-related stress is staffing challenges and poor working conditions, which we can also relate to in the table. So some people are saying facilities are operating with insufficient equipment and staff. Somebody is complaining of stress of bending and standing for extended periods of time while they do procedures because of lack of equipment and sitting. Junior doctors having multiple responsibilities. So this is a comment from a medical officer from General Hospital in Kaduna. He said poor lighting, that is when suturing episiotomy, there is no light. You use your phone light, you start having headaches. Still on the causes of work-related stress, I've talked about the multiple roles. A doctor in Bauchi said you will be the doctor, you'll be the attendant, you'll be the lab technician. It's too much for one person. So some also complained about long and continuous shifts because of lack of health workers. Somebody complained they worked from morning. They were supposed to leave at 2. Nobody came. They were there till 6 p.m. They had to pay somebody to come and take over in the facility. And then, this is really important also, patient-related stress. This is something that is becoming a problem in Nigeria. Patients physically assaulting health workers. So, nurse midwife from Kaduna said patients will expect you to just leave that one. That is when you're seeing a patient and they bring their own patient, they want you to leave that patient and attend to them. And another nurse from Kwara said some usually say sorts of abusive words to you. They even attempt to beat you up. So how does this work-related stress affect these health workers? So from the questionnaire, these are some of the things that came out. So there is reduced output. Most of them said they couldn't work at full capacity because they are stressed, poor concentration, conflict with colleagues, absenteeism. Some have constant fatigue, down to physical symptoms. Some complain of constant, they say they have chronic backache that doesn't go away. They have headaches. Some have psychological problems. And you can see, still, some of them still said no, up to 16%. So, when you come to compare and try to do regression, you really want to find out, who are these people that are saying no? Look at their cadre, where they work, and some other things, just to find out why they think they are not stressed. So some of the things that came out from the qualitative bit is that there's work-life imbalance. So they have inability to maintain work-life balance, and then this impacts on their family and social interactions. So this young doctor in Kaduna said, you hardly have time to interact with your family. You come back late, your baby is also asleep. The person in the interview was really not happy. He said his baby doesn't recognize him anymore because he leaves for work before the baby wakes up, and he comes back when the baby is asleep. So for support system, for work-related stress, we found out that there was no support system whatsoever for work-related stress. There is an absence of structured stress management and absence of clear leave rules. Despite how busy these health workers are, sometimes they are not even allowed to go on leave. So some of the comments they have there is there is no official way or support system of coping with stress. So somebody was complaining, a community health worker complaining in Kaduna, a list will be sent to the ministry. This is for leave, to indicate when you want to go for annual leave, but no application being sent will be duly signed. So even when they apply for leave, nobody will sign for them. So how do they cope with stress? What I found out in this study really is that I now understand health workers work as health workers because they love what they do. That's one thing that I can take home from this. So they said they cope with stress because of self-motivation and positive mindset. Because of the joy they derive from seeing patients, that is why they continue the work. And then they also get teamwork and support. Sometimes in facilities, if one unit is busy, they call other people to support them. And then when they have less busy times, they try to use it for some other activities, maybe to relax in the hospital. And then some other personal relaxing activities, like some say they like going shopping and other things. And occasionally when they have problems, their colleagues come together and help them with financial assistance and then social support also and celebrations. So here, in this study has found prevalence of work-related stress to be 76%, which is same as what has been found in Nigeria. And most of the problems are from work overload. So it is work overload and lack of manpower. That is what is stressing them. But you know, usually if you talk to people in the government, they will think it is because people are not paid well. But look at it, only 2% complain about pay. So actually the pay is not the problem. It is the work condition. So even the job distribution, you know, that we're talking about, maybe no job description, only 1% complain about that. But what I found really surprising is somebody complaining about transportation. You know, if you live in a place like Abuja or Lagos with distances and, you know, the cost of transportation is far, maybe you will complain about transportation, but you can see some people complaining about that. So in conclusion, addressing this work-related stress among health workers really requires a multifaceted approach, improving working conditions, implementing policies to promote work-life balance and mental health, providing adequate resources, offering training and support, and also research and data collection on the issue should continue to inform evidence-based intervention. And I really do hope that by the time I'm able to pull all the data I have together and come out with a comprehensive report, this is something that we hope to share and disseminate to the states that we did the data collection. So I'm really grateful for Johnson & Johnson for sponsoring my PhD and support from, I think, everybody here in the group from LSTM. They have really been supporting us in our PhD. Thank you very much.
Thank you so much. I know she had at least more of the content to cover, and we must appreciate that. Thank you so much. So I would like to request that for the presenters to come in front, so that now, meanwhile, you can be able to actually raise your observations, your comments. So quickly, I would like to get comments and questions from you people, so that we can. Any person who has an issue? Yes.
Thank you very much to all the PhD students for amazing presentations, and it's been great listening to each and every one of you. I have one general observation to the three, Maria, Zainab, and Umi. I acknowledge that you are literally thinking through the protocol and getting ready to collect your data. And I just wanted to reinforce that you need to consider how you will improve, observe credibility and transferability within your data, within the qualitative aspect of your data collection, rather than collecting all the data and then come back and start reflecting backwards. So it would be very helpful if you start thinking through the processes in terms of the strategies you'll use to analyze your data, what's the rationale or justification informing your data collection methods. Are they the most suitable to use? For instance, if I give an example on Zainab, the Zainab or Umi, one of you is using focus group discussions with health workers, and I was just thinking aloud how you will be able to organize these focus group discussions within the realities that the health facilities are overstretched. So having a group of 6 to 12 health workers within a group, would it impact on health service provision and so on? So these are things that you need to consider ahead of time. For Zainab, I also had one other comment. It's on, I noticed that you have Kenya, Zanzibar, and Tanzania. So if you could observe some consistency. Zanzibar and Tanzania are regarded as one country in terms of the global mapping. So if you could reflect more around that and have a justification for that, that would be very helpful.
Okay. Thank you so much for that. I hope you have taken note of that. I would like to, any other questions at the end, or comment or observation? Any? Yes.
Yeah, so thank you very much for the good presentations. My comment goes to Maria. I think we've had the presentation and it is really getting firm and good. When I listened to your sub-objective 2 on the analysis of the adaptation of the WHO 2016 guidelines in the project sites. Of course, you've said you are going to map the ANC guidelines and the like, and you are going to do some key informant interviews. In the key informant, you've rightly listed the Ministry of Health policymakers to give ideas on what influences the adoption of these policies, and maybe they can actually clarify the process. But I think that will be very one-sided. So I think I would suggest that you need to figure out how you can involve the other voices, the civil society, those ones working in sexual reproductive health and rights, or MNH, because this is the way they always look at how government responds to some of these global guidelines. Thank you.
Thank you so much. I hope you're taking note of those comments. Any other input or comment or question? Yes.
Okay, thank you so much. The presentations were very educative. I just wanted to find out for the presenter who presented on blended learning versus face-to-face. I don't know. She said that the people will be of the similar characteristics. Then I was wondering how they would avoid biasness, considering that many times when you're doing the blended learning, there are issues of network connectivity, and you will find that maybe you are doing a breakout session and you only have 2 participants, or will you only pick the people who will have participated in the breakout sessions during the Zoom sessions on blended learning? Then on issues of domestic violence, she said that your participants, you'll only recruit those that are above 18. How about the below 18, and they're the ones who are prone to domestic violence, especially from parents? When they get pregnant, they really get have it rough with the parents and also other people at school. So why have you not considered those ones? Because there are quite a number, especially in our ANC clinics, and they are the ones who are really affected most.
Thank you so much. I think those are very good questions. Any other from the team? Yes.
Yeah, mine is only a comment, and I just wish to say thank you for the beautiful presentations. And I want to comment on the domestic violence and domestic abuse. I'm not sure whether it was interchangeably used or it means one and the same thing. Maybe you can check on that. Domestic abuse, domestic violence. It's used the 2 terms interchangeably, so it's good either I don't know how you want it to appear. And the other one was about the teenage pregnancies. It has been mentioned. Thank you.
Okay, thank you so much. Any other? Okay, fine. I would also like just to add a comment to that is. I had a comment. This is to Zainab. I think I would like when you look at your rationale or maybe your background. Just a comment that I could see lots of the bad health indicators. I would wish that you also enrich with the contextual factors, for example, like COVID-19, human resource shortage, why you want to compare the two. So that now you enrich why you are doing face-to-face versus that the blended, because otherwise we're just seeing lots of your bad health indicators only in your background, and I think that may not be justifiable enough why you are conducting that kind of study. The other thing I would just want to comment is also still on Zainab, the study population, you are focusing on those 3 countries. You must think about how you will be able to handle, because of different kind of cadres we have within our countries, how will you factor in, because I could see that you only measure about nurses, medical doctors, then the other countries will have clinical officers who also train on reproductive health, so think about that. Then a question to Umi. I think that has been asked about why you leave out the mature minors. I think my colleague has been able to ask that. I would just also ask now, how are this question that you talked of a questionnaire that you had to add some questions, and I think you didn't point out whether you actually pre-tested that tool to confirm that it's able to actually achieve the issue of is it reliable. You need also to just tell us whether that is, because if you're adopting, you adopt it wholly, but if you are going to modify, then you must be able to confirm to us whether you're able to do the pre-test and actually. So just comment on that. I think is there any other question? Dr. You seem like you have a question. All right. I think, Professor, you have any question? All right. So I think now I would... All right. So I think now I would like to give them a chance to respond. And as they're responding, please make sure that you're also rating them and finish up. Huh?
Okay. Thank you very much for the question, Peter. And before I answer the question, your question, Alice, your question to them, your response to them about the focus group discussion. So maybe I will just share, from my own experience, because I did focus group discussions for health workers. So what I did was, at the beginning, even before you got there, I think we started this discussion with Umi and Zainab. It took like a month to prepare, so you've already given them your participant information sheet. So by the time you come to the field, you would have selected those that have agreed to do the focus group discussion. So this is not something you do in a facility. We all did the focus group discussion over a weekend, and that means you give them transport money, you give them food, you look for a comfortable place. We had to hire a hotel, invite them, just tell them it's for a few hours, and they come. Because I just feel, what you're doing, you still need to have a focus group discussion. So not to just look at that, maybe you will start thinking around that. So Peter, yes. So what I have added to the questionnaire, I adapted it wholly, and there were so many questions. But the part that I just wanted to find out, like this question on how do they cope with the stress, it was not in the questionnaire. This was just talking about how the stress, affects them as health workers, whether they have, there are so many other things I have not reported, things about symptoms like headache, lack of sleep, what exactly in their job causes problems. It's a questionnaire that, although used widely, but it was piloted first in the Netherlands. So some of the things that are a problem to them, like they talk about fumes, they talk about whether the temperature is too cold, so all those things don't really relate to us directly. So that's why I just added a little bit, not too much, about 3 or 4 questions to the health workers, So in your own case, like the question, that table I gave, I asked them a question freehand. So you, in your own job, what causes stress to you? So they gave so many things. I was one that put them, just try to look at all the responses and put them in sort of like an order like that. So that's why I added those questions to the tool. Yeah, thank you.
I think since I'm not sick, I think I'll stand up. Yeah. Thank you so much for your contribution, Alice, Dr. Alice, and Dr. Ryle, for your contribution. I think I'll take all those into consideration. I will look at the recipients of the guidelines and see what they think about the contextualization of the adaptation, and I'll also take into consideration what you've suggested for my data collection. Thank you.
Thank you. Thank you all for your comment, Dr. Alice, Peter, and so on. So for the set of question, sorry. Oh, okay. Sorry, I'm allergic, so yeah, I'm taking cetirizine so that I feel bad. I'm not feeling good. So thank you, as I said, Dr. Alice and Peter, for the question. How would I pick how dealing with the issue of similar characteristic for blended learning and face-to-face? Here, what I mean, similar characteristic, both sides. I mean for the participant for blended learning and for the participant for the face-to-face. For the participant for blended learning, I will recruit the participant who are healthcare workers. It depends. As Peter says, I need to think about other cadres to see in other healthcare facility, because some healthcare facility, even clinical officer, they working there. So all cadres that are working in the NC and the PNC will include in the blended learning, as same as in the face-to-face. So for the issue of connectivity, for blended learning, it takes a time, because there is part or for self-directed 2 weeks. For the participant, they have a time to read. And for the Zoom session, most of the time it could be in 3 days. So the participant, they are telling before to be prepared to make sure they have an internet access. So they find the area where they can get a good internet in order to participate very well in the training. And also they have paid for bundle. So I think it could be able, and they have well participated in the training as same in the face-to-face group. Thank you. Oh, sorry.
Yeah, thank you very much, Alice. Yeah, we've started that discussion already, and looking forward to meet you again regarding that. Yeah, we'll discuss it later. And thank you very much for the comments. So for why I'm using from the age of 18, to be honest, I've not really concluded. Yeah, I've not really concluded from what age I am going to use. I just put it there. Yeah, until I finish my study protocol, and then we will decide together with the supervisory team on from which age we're going to include. Thank you. And regarding the domestic abuse, confusion of domestic abuse and domestic violence, I used both. I think it's a typing error. For my systematic review, I'm using domestic abuse as it captures more of the symptoms, or I'm not sure what word to use. But then for my protocol, I'm using domestic violence. So I think because I was preparing both, I tend to interchange the words. Yeah. So I'm using domestic violence only for the protocol. Thank you for the correction. Thanks.
Okay, thank you so much. I think I must admit that those are very good. I just want to hand over to Prof. to make some comments.
Yes, let me make some comments. So I just want to say thanks to everyone for all your contribution and for listening to the PhD students. I feel whenever they see me now, they're always shaking. Two people here look physically ill. The only thing they have in common is me. So I'm feeling very bad now. But I think you've all done a good job. It's always good to have deadlines, and then it helps to push people. And I think what we're trying to do, like I told you before, is primary prevention. We're immunizing you to challenge. You're able to think on your feet and it is based on a lot of hard work that you have done. So I think you know areas that you need to go and improve on. I have detailed notes and comments for you people. I will not subject you to public humiliation in any way. But just congratulations, well done. I think you've all done a good job, and thanks again to everyone. Thank you.
Thank you. You may take your seats, and I would like to hand over to Dr. Ryan. Thank you.
All right, so thank you very much on behalf of the organization. We are happy with the presentations that have happened this afternoon in this session. And yeah, I think it is really, the work is progressing. By next year, I think we will be hearing really some high rate kind of, findings and report and all that. So I just want to sincerely appreciate all of you, and we've come to the conclusion of this session. So we will proceed back to the main hall for closure of this afternoon session before the social event. Thank you very much.
Thank you.